Good afternoon. Welcome to Preventive Medicine Grand Rounds for January 12th, 2022. Happy New Year. I'm Antonio Neri from the Division of Scientific Education and Professional Development. The Preventive Medicine Grand Rounds is sponsored by the CDC Preventive Medicine Residency and Fellowship, as well as the Health Resources and Services Administration Bureau of Health Workforce. The PMRF provides 12 and 24-month full-time longitudinal service learning opportunities with senior public and population health leaders to physicians, veterinarians, and nurses who have completed the EIS program or have equivalent public health experience. You can see we use Zoom for the audio and presentation and the question box to pose questions. There is no live chat. Note you can pose questions via the question box at any point during the lecture, and the speaker may work on answering them during the time or later at the end of the presentation. Note your name may appear associated with the question that you posed. If you do not want this, you can simply click the Submit Anonymously box when you submit your question. Continuing education credits are available for the live course for up to 1 month after the presentation date, and for the recorded version up to 2 years from the date of the presentation through the CDC Training and Continuing Education online portal. The course code for this Grand Rounds is all capital letters CDC PMRF. Again, all capital letters, CDC PMRF. If you have any questions, please contact myself or email the program at prevmed@cdc.gov. You can see that we're using live captioning for this video, and you can enable live captioning at the very bottom of your screen and click on the button that says live captioning. Please remember that the views presented by the speaker are theirs alone and do not represent CDC, the Department of Health and Human Services, or the US government. Today's Grand Rounds will be entitled Building a Better Public Health Safety System, Multi-Sector Partnerships Are Key by John Auerbach. Welcome back, Dr. Auerbach. Had been at CDC for a while, Trust for America's Health, and has a very diverse career, and we're super excited to have you. The presentation will be 1 hour with 30 minutes for questions and answers at the end. Thanks, Dr. Auerbach, for coming. The floor is yours.
Well, thank you very much, Tony, and hello, everyone. I'm delighted to be here and glad to be talking about this topic because I think it's such an important topic. It's clear that this has not been an easy time for CDC or for other public health agencies in America. The state, local, tribal, and territorial public health agencies like CDC have had to address the magnitude of the pandemic and its continuing evolving trajectory. Public health leaders have been criticized and threatened, and many have lost their jobs. And all too often, our science-based guidance has been ignored, resulting in elevated risk to the public. But at the same time, there's no denying that the pandemic has elevated the understanding of the importance of public health and created an opportunity for us to address some of the long-standing problems and obstacles to the sector's optimal functioning. And can we show the first slide? Great, thanks. And let's move to the next slide. Thanks. Well, in the hope of shedding some light on where we are as a sector and where we need to go, I'll focus on answering these 3 questions. What's behind the current situation? By which I mean, how did the public health sector find itself in less than optimal circumstances? Number 2, what is the CDC doing to address these circumstances? Here specifically, I'm talking about what CDC together with the support of the administration and Congress are now doing. And third, what does this have to do with partnerships? And particularly here, I'm focused on non-traditional partnerships with those outside of the public health sector. Next slide, please. If we're going to emerge from the current less than optimal situation we face, the public health sector needs to understand what's behind the difficulties that we faced. And there are no simple answers, obviously, but let me propose that there are at least 3 key reasons for the challenges we face. Next slide, please. First, we've seen a dramatic increase in the number of public health emergencies. These are overwhelmingly objective measures of emergencies that rise to the level of the federal designation as such. And just look at the significant jump from just 10 years ago to where we are now with the federally designated public health emergencies. And keep in mind, this is before COVID, but we've seen this great increase in terms of significant public health events. Next. There aren't just more emergencies. There also is a greater range of the types of emergencies and health issues that we're dealing with. Just consider that in the pre-COVID emergencies we were addressing, they included more and more weather-related emergencies. They included the opiate epidemic, the increase in Alzheimer's and other forms of dementia that rapidly are going along with the increase in the size of the population that's over 65. Obesity levels, which are continuing to rise every year, new and dangerous tobacco products like flavored e-cigarettes, and of course, an increase in the novel viruses that we were facing, from West Nile virus to H1N1, Ebola, Zika, and now, of course, COVID. Next. So you might think that as a result of the dramatic increase in public health issues and emergencies, there would have been increased overall resources for the public health sector. Yet the opposite is true. While there's been something of a roller coaster in funding, when certain emergencies occur, there is short-term funding that usually is awarded after the beginning of the emergency. And that funding tends to have a sunset date to it, so it goes away quickly. That's left core public health funding relatively flat. This looks at total state public health funding, and you can see that the amount that was available in 2015 is actually lower than the amount that was available in 2008. Next slide, please. This chart is illustrative of CDC's funding, and it's adjusted for inflation and also eliminates one-time only funding, including short-term funding for specific emergencies like Ebola. It's also perhaps worth noting, this is relatively flat, as you can see, but it's also worth noting that there were certain line items of CDCs that were dramatically cut during these same years. For example, the Public Health Emergency Preparedness, or FEP grant, was cut by a third from the initial funding level post 9/11 to the funding level that immediately preceded the COVID pandemic. In addition to that, funding at HHS for ASPR, for hospital preparedness, was cut by 50% during those same years. Next, please. It's not only the budget, but the workforce also has been dramatically affected. This is a slide that shows research that was done by ASTHO, the Association of State and Territorial Health Officials. And what it indicates in that chart at the bottom is the decrease in the total workforce that were employed by state public health departments in a period of time from 2010 to 2016. During that relatively short period, the state public health workforce shrunk by 9%. Next, please. And the local public health workforce shrunk even faster and more dramatically, with a 20% reduction between the years 2008 and 2016. So to restate the obvious, just as the number and type of public health emergencies and issues were growing, the capacity of the system to respond was being crippled by reductions in the workforce and inadequate funding. This slide, by the way, is data that were gathered by NACCHO, the National Alliance of County and City Health Officials. Next slide, please. The third point I would make is that even when there is funding, it often comes with strings attached. Usually the funding for public health can only be spent on a specific disease or condition. So just for an example, how unusual this is in regard to a number of ways that public funds are distributed. When I was a local public health official, I was the Boston's health director for about 9 years. My budget was much lower than the budget of the Boston Police Department. But the Boston Police Department only had 3 line items in its much larger budget. And so it was able to have much more flexible funding. Its line items were for, one was law enforcement, one was training, and underneath that line item, great flexibility. In my department, I had more than 50 line items, and I wasn't allowed to move a penny from one line item to the other if there was a greater need that arose unexpectedly during the year. This chart, by the way, is developed by the University of Washington, and it illustrates the obstacles to responding as needed. The different colors on the left-hand side of the chart represent the sources of funding coming to an average state public health department, while the categories on the right represent the required uses of the funding. And they're actually clustered. If we broke them out, there'd be 50 or more different lines there. And this sort of just gives you a sense of the complexity, because each of the funding sources has different rules and responsibilities, and the funding may go up or down in a year. And this is just what it's like for a single health department to try to manage that uncertainty and stay within the lanes of requirement in the ways that funding is given out. Next slide. In addition to that, as you know, we don't have a national public health system, so funding differs significantly from state to state, meaning that there is no uniform set of expectations that the public or CDC can have regarding what the state, local, tribal, and territorial public health system can provide. Next slide. To summarize the reliance on specialized or categorical funding, it results in some real challenges, and those aren't just about responding to emergencies. It also limits the ability to respond to broad issues that affect health, like racism or the social determinants of health. It makes it difficult to support grassroots organizations that serve populations that are based on a variety of needs and not a single health issue at a time. Next. So those 3 points illustrate some of the significant obstacles to our being ready to respond to a major emergency like COVID, or some of those routine day in, day out health situations that we're facing. So let me tell you some of the more recent news about what CDC is doing to address these problems. Fortunately, CDC is taking some steps that are helping the public health sector overcome some of the historic challenges it's faced. Because COVID has been an unprecedented emergency, it has graphically demonstrated that there's a price to pay for neglecting the public health system. And as a result, policymakers in the country, and that includes those at the federal level, have responded, at least in the short term, with funding and greater attention. And the CDC has benefited from that additional funding and attention, and when possible, attempted to utilize it in ways that not only address the current emergency, but also may have a lasting impact on the public health sector. Next. And next. So what are some of those examples? Well, one of those key examples is about the data modernization effort that's so much needed. CDC, as I suspect many of you know, is now overseeing a potentially transformative data modernization efforts, or DMI. DMI is at the heart of a national effort to create a modern, integrated, and real-time public health data and surveillance system that can protect us from any health threat. And it's a multi-year billion-plus dollar effort to modernize core data surveillance infrastructure across not only the federal level, but the state, local, tribal, and territorial public health landscape. And it's a move from siloed and outdated public health data systems to connected, resilient, and sustainable ones. CDC is connecting with partners from across the stilt public health levels, as well as the private sector, to achieve its goals. Under the leadership of Dan Jernigan, this comprehensive approach to data system relates directly to my earlier observations because, for example, we've seen how important timely multi-sector data is to responding to the current pandemic. And we've seen how important this is if we're going to promote equity and reduce the disproportionate impact on unhealthy conditions and on marginalized populations. There's no denying that we are unable to strengthen the public health system unless we address the data needs of the system. Next slide, please. Another essential area that we have to address is the workforce. As I indicated before, a strong public health workforce is vital to public health. And given the cuts that I was mentioning, we need to increase the investments in the public health system. And although efforts to promote priorities for the public health workforce for specific disciplines are important, promoting shared priorities with more of an integrated approach will amplify the impact on the public health workforce as a whole and benefit public health disciplines. CDC now has an opportunity to do just that. We have received more than $7 billion in public health workforce funding. Most of the funding goes out the door to our state, local, tribal, and territorial or still public health sector partners and other partners. I'll give you a few examples. There's the AmeriCorps program, which is currently in the planning stages, and in just a few months will launch a public health workforce initiative. There's another example of a $250 million community health worker initiative where the funding has already been distributed and personnel are now being recruited from the communities most affected by COVID and other diseases. And really significantly, there's a NOFO, or competitive procurement opportunity, for $3 billion in funding for the workforce that will be released in the coming months, offering greater flexibility than in past grant programs to hire the staff who are needed without disease-specific restrictions. Patty Simone at CDC is overseeing that effort. It is worth noting, though, that both with DMI and workforce, attention is going to be needed to sustain the gains that will be achieved with the current investments, because the current investments largely rely upon COVID-related funding, which has a sunset date. So we have to keep our eye on sustainability. Next, please. It is really important as well that we think about the efforts to address key issues that are cross-cutting, as I'd mentioned, that don't really fit into a disease-specific approach. And here too, CDC is making real advances in how to think about that. Next, please. CDC is taking steps to provide resources and support to the public health system to work on issues that have a major impact on overall health. And two key examples of those are promoting equity and addressing the social and economic factors that affect health. So some examples of the response involve more than $2 billion in COVID funding has been targeted to Black, Brown, and other populations of color that have been historically marginalized. In addition, specialized funding for social determinants of health have, for the first time, been distributed to states and locals. And internally, CDC is ensuring that every center, division, and office is reviewing its own work and making equity part of its DNA. There's an unprecedented cross-agency effort now as well that's focused on the social determinants of health that involves hundreds of employees and an ambitious agenda. These efforts internally will have implications externally as well by affecting our policies, programs, and grant making with our partners, but they also will serve as role models for those that are in the public health sector at other levels, demonstrating how each sector needs to adapt to meet the needs of the public health in the present period and the future. Next, please. A clear and resounding example of the importance of taking action on these kinds of issues is Dr. Wolinski's declaration that racism is a serious public health threat. She joins states and locals who've made similar declarations, and she asserts the relevance of the public health sector and the importance of the transformation of its work in order to address racism. Next. I mentioned earlier that our work on equity at the agency is in every single center, division, and office. And one example of that is under our comprehensive core initiative. A component of our core initiative has involved requesting that every single division and office develop goals to address equity. And this has resulted in 159 goals that are across the agency now underway to try to ensure that health equity is fully into the fabric of all that we do. We didn't want to just pigeon equity into one section or two sections of the agency, but make sure this is truly part of our DNA. Next. We've also taken that same approach around the social determinants of health. Our work on the social determinants of health is based upon its recognition of its importance, as illustrated by this chart, which reinforces that fully 40% of the impact on the overall health of the population is due to social and economic factors. But in addition to that, next slide, please, CDC has been involved in promoting policies that are both traditional and not so traditional to reshape our work. And an example of that is this program. It's the High Five, or Health Impact in 5 Years program, that has scoured the research to find the policies that, if put in place, will guarantee that health improves in 5 years or less. And it's identified 14 evidence-based policies. Interestingly, and somewhat unexpectedly when the work began, about half of those policies involve sectors other than the public health or the health sector. They involve work to address income, housing, the environment, and education. And this is a reminder of the final point and a key point that I want to make today. And that is namely that in order to improve health, we need to form and strengthen partnerships with other sectors, including non-governmental organizations. Next. So let me move on to the final section of my presentation today. I've already talked about the importance of partnerships in some ways. You've heard me repeatedly mention that we have to pay attention to our still partners, our state, local, tribal, and territorial partners, and our workforce efforts that require community partners. We can't have an AmeriCorps or a community health worker initiative unless we have strong ties to organizations and individuals at the community level. And in addition to that, the DMI effort relies upon both public and private partnerships to succeed. But Dr. Wolinski wanted to increase even further our dedication to working across sector and to working both intergovernmentally and with non-governmental organizations. She wanted to prioritize relationships and partnerships as part of an overall plan to advance health and well-being. So let me offer some examples of those partnerships and share why they matter in the reshaping of the public health sector at all levels. Next, please. So let me start at the federal level. Inside CDC, we are working to break down silos, the traditional silos many of you have heard of that exist at CDC. And we're doing that with cross-agency collaborations on key issues that affect health concerns and that relate to many different parts of the work of CDC. One of those I've already mentioned, and that was the cross-agency collaboration related to social determinants of health. We also have one that's focused on climate change. Now, these two collaborations are more than loose gatherings of individuals at CDC. They each involve more than 100 employees and scores of different divisions within the agency. And the people involved will come together to do both joint planning and to take unified, multifaceted action steps. In addition to working within the agency, we're working within the Department of Health and Human Services to strengthen our partnership with other health and human services agencies. I'll give you an example of work that we're doing with the Office of the Assistant Secretary for Health, for example. Under Admiral Levine's leadership, we're involved in cross-agency work on primary care, on climate change, and on equity. And in other parts of HHS, we're working with other agencies within the department on the social determinants of health. And then that final bullet, the interdepartmental linkages. We're reaching out to other federal departments other than Health and Human Services. We actually did a survey across the agency to find out how many of the programs at CDC were already working with other federal agencies like HUD and the Department of Transportation. And we were really surprised to see just how many initiatives were underway. Literally scores of them were underway. They weren't always linked to each other, and sometimes we didn't have a strategic view about how to develop a partnership with those agencies, but they really showed great work, and they showed the skill and understanding of CDC staff about the importance of working with other sectors. An example of that is with HUD, we're working on addressing the needs of those who are homeless and jointly taking steps to reduce homelessness. And we also have unified efforts to support affordable housing and housing that promotes the health of some of those that are the most vulnerable. You know, as a former state and local health official, as well as a CDC official, I'd say that kind of work is core public health. Next slide, please. And just another example of efforts that we're involved in with other departments is we're working with the Department of Transportation. The Department of Transportation, like a lot of other departments in the federal government now, are facing real opportunities that they haven't faced in the past. So as an example of that, the Department of Transportation in the recently passed Infrastructure Act received a kind of staggering figure of more than $500 billion to help to transform the aging transportation systems within the nation. This chart shows just a small portion of where the funding was going, but it illustrates the ways that the work that the Department of Transportation has real impact in terms of health and well-being of the public, and suggests ways that the public health sector could be working with the Department of Transportation. For example, two of the items listed here were on that earlier list of the High Five program of evidence-based initiatives that improved health. They were specifically alternative fuel vehicles and public transportation. So these are proven public health initiatives, and we're reaching out now and sitting at a table with the Department of Transportation to talk about how we can support them and how we can ensure that the public health officials at the local, state, tribal, and territorial levels are aware of how much money and for what the Department of Transportation will be distributing to their communities, and considering the ways that they can collaborate with the transportation officials in their municipalities. Next, please. I want to give you another example of a partnership and how it is quite significant. And this is a partnership with an agency at the Health and Human Services Department. We have weekly meetings now between leadership at CDC and CMS, and those have become more and more ambitious and meaningful month after month. We're working on such issues as unified data systems, on joint equity initiatives, and of course on the COVID response. And we've assigned staff from CDC to work full-time or near full-time with or at CMS as an indication of our recognition that this is an important partnership. This builds on work that's gone on for years with programs like Million Hearts and 618, both of which are continuing, as well as very important work that's been done to work on improving quality in a variety of different healthcare facilities, from hospitals to skilled nursing facilities. So this is an example of a partnership where we should be joined at the hip and continually working with each other in a strategic as well as a program-related way. Next, please. So moving from the federal level to the state, local, tribal, and territorial governmental level, I would just say in terms of these partnerships, we really treasure the leadership at these levels. These are our public health closest partners, and they need our support, especially at this moment, because they've been unfairly and sometimes viciously attacked during COVID, and we need to defend and support them. I would say I've been astounded in the 6 months that I've been back at CDC with the frequency of the communication between CDC and these partnerships. Virtually every day there is a call that takes place to update our partners and to hear from them. We're fortunate in that our Center for State, Tribal, Local, and Territorial Support, or CSTILS, has skilled staff, scores of staff whose job every day it is to provide grants, technical assistance, and training to these partners, but also to listen to our partners at this level and respond to their concerns, appreciate and highlight their successes, learn from the lessons from them, and understand their needs. And just as our work has involved forming partnerships with non-health sectors at the federal level, like DOT and HUD, we need to support the still public health agencies in efforts to work with their own partners in those other sectors. Sometimes we at CDC have direct contact with some of those non-health sectors in states and locals, for example, in schools, and those partnerships are very important too. That said, we know that this work has room for improvement, and we've learned and still learning about the ways to strengthen our communication and coordination. But it's a priority to continue to strive to make these partnerships as effective as possible. As you heard me mention a minute ago, I'm a former state health official. I was the health commissioner in Massachusetts for 6 years, as well as a local health official in Boston. And when I first worked at the CDC several years ago, there weren't many other people like me in the agency in leadership who had previously worked in those kinds of positions at the state and local level. Now that's no longer true. Now there's a record number of leaders who've had experience at those levels. For example, 3 of our deputies were former state and or local public health directors. 2 of our center directors were state or local health officials. And we have former STILT leaders in scores of other positions, from data modernization to HIV to emergency preparedness. And bringing this kind of experience from the field into CDC enhances our work, and it also makes our partnership with people at those levels that much stronger. Next, please. So finally, we're working to expand our partnerships with nonprofit organizations. Among the priorities that we're setting as we're thinking about those in the non-governmental sector are strengthening our partnerships with civil rights and social justice organizations. And this relates very much to our commitment to equity. And it has to do with ensuring we're learning from the wisdom and skill of those organizations and their members, and whenever possible, providing them with the resources they need to expand their focus on health. I'd highlight as an example the important ties that we have and are strengthening with the historically Black colleges and universities. And among other reasons that those partnerships make sense, those schools are training the public health leaders of the future. And we want their students to consider CDC and state, local, tribal, and territorial public health agencies as possible future employers. And we want to look to them to provide leadership in the coming decades. The public health sector also needs to extend our partnership from the national level right to the grassroots community level. COVID has reinforced the importance of establishing these ties. We have to build trust, and their trust is only built over time. More and more efforts are being made to determine how we can work best to direct funding to local community organizations that represent the populations that have been historically neglected. And some of the new efforts, for example, the community health worker grant program that I was mentioning are showing us the ways to do that. Our public health partners at the state, local, tribal, and territorial level are closer to those communities, and we need to be supportive of them as they establish those connections too. And that we all learn to listen to the voices from those communities and the leadership of those communities as we're developing and implementing policy. Now, there are many other sectors that I haven't mentioned, many other partners, really important partners that I haven't mentioned just because of time. And I'll mention just a few of those very briefly. It's incredibly important that we work well with the healthcare sector. And that includes the federally qualified community health centers, many of which really operate as public health entities in themselves. Those partnerships are incredibly important. And over the last several years, particularly since the passage of the Affordable Care Act, some of the care, the direct care that public health departments at the state and local level were providing to uninsured residents of their communities have switched over to the federally qualified community health centers as those uninsured patients gain greater access to insurance. So we need to work well with them, as well as with others in the healthcare sector at the hospital, primary care, and skilled nursing facility levels. And an important part of the work that the Data Modernization Initiative is engaged in is determining how to link our data systems so that we don't create complications, but we take advantage of the utilization of electronic medical records, for example, to channel some important information to the public health sector. A second partnership sector that we need to pay attention to is the business community. And here we haven't paid as much attention as we might. The major employers in the country play a really important role in reaching their employees, but also in the larger civic life of their communities. And so ensuring that we're working with them, we're providing them with information as they need it, but we're also listening to their concerns and issues that are arising from them matters a lot. And so there's been more and more attention to working with the business sector, but this is an area where there's definitely room for improvement. Just a third area I'd mentioned, and again, there are just many, and I'm not going to mention them all, is we have really learned the importance of working with public schools across the country. When I was a state health director, during H1N1, we worked with our public schools every day because we had to advise them about when to stay open and when to close. And now we clearly are having a major impact on the way that schools are operating and functioning safely as possible with our guidance. So recognizing the importance of working with the education sector at all levels, including at the national level with the Department of Education, but also with that smallest local school is key to the public health sector, and we need to continue to pay attention to that. So for my closing remarks are, you've heard me say that there's something, oops, one more, please, thanks. You've heard me say that there's some areas we're doing well, we're doing better, and there's some areas where there's definitely room for improvement. And I think it's okay and important, in fact, for us to say that there's still work to be done if we're going to get to the new North Star of the public health sector, that new North Star that is able to work from the community level through the local, state, tribal, and territorial level to the federal level to address key issues like the social determinants of health and racism, that has the capacity to provide real-time data to the public, that draws data from multiple different sectors. There's a lot that we need to pay attention to in that new North Star. And we're really on the road more than at the destination. Maybe we're just beginning to be on the road towards that new North Star. We need to acknowledge the challenges of the past as part of our pathway to the future. and we need to recognize that we've got some bumps in the road facing us now and in the future. We need to continually be trying to learn the lessons, and the lessons are being learned at all levels, from the community level through local, state, tribal, and territorial, and at CDC. Make sure we're sharing those lessons. We need to keep our compass clearly focused on the direction needed to identify and address the health needs of the population, not just now, but we need to project them into the future. In spite of COVID and the monumental response that it's required, I believe we're actually making progress in terms of moving along that road to a new, modern, healthy public health system. But we can't take our eye off that new North Star, because there's plenty of work ahead of us. And with that, I think I'll end my formal talks and look forward to your questions and comments, I think some of which have been coming in. So Tony, maybe I'll turn to you and see whether there are any specific questions or comments that people have.
Thank you, John. Thank you for taking your time today in your presentation. I have a couple questions, and I was trying to consolidate them into a few areas. One was related to that some people had posed, was this efforts to de-silo or decrease the amount of siloed communication is probably the best word I could use for it. And your experience at the different levels of both public and then nonprofit organizations in doing so and leading that sort of effort.
And Tony, just to clarify, is that siloed functioning, like the different programs operating independently of each other? Is that's the main focus?
I think that would be one of the key concepts within communication. People always say you can never over communicate. Maybe on Twitter you can, but you can never over communicate. And I think that communication, one of the questions was about communication and increasing communication among centers. But I also think it actually comes back to an organizational approach to collaboration. And I was interested to hear, and there are a couple of questions related to that.
Yeah. You know, I first of all, I would say I think it's difficult to do. I've led big departments at the local level and the state level, and now I'm working at CDC. And I would just say the nature of large organizations is the work can easily become siloed. But I think the things that can be done to improve that kind of situation and break down those silos. And I gave one example of that. I think if you would recognize that there actually are issues that cross the traditional ways of thinking of health issues and unify them, that provides opportunities for people to sit at the same table and be jointly working. This comes up very much in terms of dealing with the promotion of equity, for example, because I would say in different jobs I've had, if we wanted to work in a particular community, like we would identify, let's say at a local level, the Latino community where there was a range of different health issues. But if we were funding each program separately, we sometimes didn't even know what each other was doing. We'd be funding the same organization and didn't realize it. But if we sat at the same table and shared data, talked through what the issues were, and talked about how we could work as a team, that began to change the way that we worked, and we worked more effectively. So I think at a big agency, federal agency level, I think it's been brilliant to begin those cross-division collaborations on social determinants of health and climate change. My own experience is that that's gone way beyond what the initial expectations were when Dr. Wolinski said, those are two areas of priority for me. I'd like people to come together. What we found was opening up the opportunity was like a floodgate. People throughout the agency said, you bet, I want to work on those issues and bring my particular area of work to the table. So I think that's very important. You also, though, or the listeners have also just raised the issue of communication. And I do think, like you say, you almost can't communicate too much. I think, and it's very difficult when you're in a situation where the news is so fast moving, that the news from yesterday may not be as relevant as what just happened. I think that really speaks to the importance within organizations and across organizations of our developing the most sophisticated communications approaches, whether that's daily newsletters, whether that's blogs, whether that different kind of forums. I think that those are important. I'll give the example of one of the things that Dr. Wolinski is doing is as COVID policy changes, she's been holding CDC internal meetings for all staff to be able to hear the latest and to ask questions. With the notion that this isn't just an issue that the infectious disease folks will want to talk about and know about. Every single person, regardless of their job, will want to get the latest information and have an opportunity to ask a question. So I think there's a lot we can do, and I think we need to not just hope it happens. I think we need to be conscious in terms of our efforts to break down those silos.
Thank you. One of the follow-on questions to that is what's the impetus for these external partners to work with public health? What's the driver that pulls the HUD and DOT and all these other, or HUD's more of a traditional partner, like Department of Transportation is not a traditional partner, but what's the initiative that pulls them together, that pulls us together?
Yeah, I think that's a great question, because the answer to that is there has to be what brings us together has to be a shared interest in accomplishing the priorities that each agency has set, or that the administration we're a part of has set. It can't be that the public health sector has a set of priorities and it's just going to go in and try to convince every other department that our priorities should be their priorities. I would say I've tried that. I've tried doing that in my past jobs, and you don't get very far. The place where you really make progress is where you understand where different organizations and agencies are coming from, and you attempt to build a partnership based on each agency's self-interest. So I'll give you one example of that from when I was a state health official. We had the legislature passed a bill that said that the Department of Transportation had to pay attention to health in its major transportation projects. And so they reached over to us in a health department to say, we don't know how to do that. Can you help us do that? And we didn't have a transportation expert. We had someone who was terrific at chronic disease. And so we assigned her to work with the Department of Transportation. And I would say the first 6 months were no progress was made, because our person went in there with the public health lens of just saying, here's what you need to do. The transportation people heard that as everything you're suggesting is going to cost us more money or delay this project. And we're evaluated on working within a budget and getting things done on time. So you're very nice. We appreciate how idealistic you are, but we're not able to do what you want to do. She could have just quit and given up, but she stuck with it. And at about the 18-month time period, it really took that long. She said, I've got it now. I know their culture. I know their motivations. I know their priorities. I know how to work with them to have health incorporated into their planning in a way that helps them accomplish their goals and at the same time improve health. But it took her time to understand what their concerns were, as well as what the opportunities were. And once that clicked, then it made for a really fruitful partnership. So as we're going into HUD and transportation now, we're looking for those shared opportunities, the places where we can begin with shared goals. And we want to have some successes, and then we can build on that. And that may then open the opportunity for either us to be supporting them in something that maybe wasn't on our table, or vice versa. An example of that is homelessness, where we were really concerned about the health of people who were homeless during COVID, and ending homelessness was part of HUD's mission. So putting us together at the table allowed us a shared interest in working with a particular population. And we can now build on that on those relationships and the understanding of what we have in common.
And I think one of the other examples that I've found pretty interesting in my time with PMRF and putting people in state and local health departments has been the Affordable Care Act, and particularly the Community Health Needs Assessment and the Community Health Improvement Plan, and that relationship to private entities, healthcare entities, and their requirement as accountable care organizations to come to the table with a community health assessment.
That's a great example. That's a great example, Tony. Thanks for raising that.
And that ties back into another question about elected officials. And there's a couple questions in the question and answer box. And if you're out there listening, you can put a question in the Q&A section. We'll try to get to it in time. But related to this idea of fractured funding, and so the ability, and having been outside of federal government for a bit, and having been in state and local government, sometimes in which you can interact with officials. You always interact with officials, but it's in different ways with elected officials. But I was wondering if you could talk a little bit about that and how to, I guess you talked about managing it, right? And sort of the difficulties therein in appropriated funding and line item funding versus discretionary funding, but influencing that, or being able to, I'm not using the right word, but being able to work with elected officials to try to achieve public health outcomes. Maybe that's the best way. And that can occur through policy, it can occur through a lot of communication mechanisms, but maybe expand a little bit about on your experience in doing that.
Sure. You know, the way that the background to why public health has such a different and very specific way that funding comes with those scores of line items has everything to do with the issues that have been identified by elected officials. Sometimes that's their constituents will say, hey, you're not doing anything on a particular issue. And so they will look to creating a line item that will be sure that that issue gets paid attention to. And I've certainly had that experience. Sometimes I had the experience of individual elected officials in their family have an issue, and they'll take up an issue particularly because of that. And so over the years, that has just meant one issue after the other. There isn't funding that's, you know, here's your discretionary budget, public health figures. You can just go off on your own and figure out what to prioritize. That said, certainly at the local and the state level, the more that there are processes in place to analyze the data independently of where funding is and to try to identify, are there emerging issues, are there unmet needs, and also to listen to the voices from the community about what matters to them, can help, I think, to make a stronger case to policymakers that there are certain issues that need particular attention. I'll give you one example too, again, not to bore people too much, but when I was a local health official, I would present data in multiple neighborhood meetings where I'd bring the data in and say, here's what your neighborhood looks like in terms of its health and well-being. And then I'd say, and what do you agree, disagree, what did we miss? The first time I did that, the first year I was a local health officer, the first person at the microphone said, you didn't list housing as one of the health issues to address. This is maybe 15 years ago. I said, well, no, housing is certainly important, but you misunderstood me. I said health issues. And so I was looking for health issues like diseases and injuries. And she said, well, no, you know, Mr. Public Health, you're wrong. Housing is a public health issue. And a few other people in the audience kind of really made that case to say, your priorities are off. So that allowed us that kind of experience of hearing from the public that they wanted us to pay attention to housing conditions. We then went to our elected officials and shared those stories and asked them if they could think about ways to fund improvements in housing from a health perspective, and that funding actually ended up, passing. So I think having that kind of relationship with elected officials, again, at the state and local level. At the federal level, that's a whole different thing. I'm not involved in that arena. But at the state and local level, I think that the key is using your data, having really good data to demonstrate a need, and then listening to the community and bringing the community voice to elected officials. I think that often is what makes the difference.
Thank you. And then there's a little bit more, and this is maybe a follow-on question to that, but this ability to someone was talking about diversifying funds, right? Diversifying their opportunities. And you provided some examples related to Department of Transportation funding. There's a whole lot of funding coming in the most recent bills related to broadband internet funding. I wonder if you could talk a little bit about your work in being able to have people that are flexible in which they're able to work across sectors. You spoke a little bit about it, but if you could expand a little bit more on that. And particularly, I think it seems more common to partnership across sectors nowadays than it was back when you're in Massachusetts or Boston. Yeah. And maybe your experience back then versus now.
Well, I think that there's been a very notable recognition that social determinants of health are a thing, and that they have an enormous impact on the health and well-being of the public. The term social determinants of health, I don't think we heard that 10 years ago. But now it really is, I think, increasingly understood in a concrete way. In some ways, it would be best if you had specialists in social determinants of health who worked in state and local health departments who had familiarity with those other sectors, so that they could develop the relationships, understand more about the culture, start going to meetings in the community that relate to those other agencies. And I think more and more local and state departments where they have any flexibility are trying to designate someone to do that. But it's difficult if the funding only comes categorically. So in the future, if there is more flexible funding, then I think state and local health departments will be able to have someone trained as a flexible person to work with those other agencies. The fact that there now is, for the first time in history, a line item at CDC called Social Determinants of Health, where the money went out to communities to help to understand that work better. And that there is in the upcoming competitive NOFO for the $3 billion, greater flexibility in deciding how to use that funding than in the past. The specifics are not determined, but it looks like that funding will give the recipients greater flexibility than the sort of disease-specific approaches of the past. That, I think, those kinds of efforts do increase the likelihood that there will be some designated people and expertise that develop to make sure that work happens.
Yeah, I think as an agency, we've been good about starting to identify social determinants of health, and I think we're learning as an agency about evidence-based interventions for social determinants of health, and I'm pleased and excited to see that progress. I was wondering if you talk. There's two questions. One about rurality or rural populations that I don't think you touched on too much, but then also religious organizations and their role in this sort of new North Star, this way in which we're functioning.
Yeah, so that's great. Well, let me start with the religious organizations first, and I think that is another sector, if you will, that we should be paying attention to. The voices from the pulpit often influence people's behavior. And we have certainly seen in different public health initiatives that when we work with those that are the clergy and religious leaders, they can have a significant influence. So, I started out my career in public health doing work on HIV, and when we established meaningful relationships with clergy, that just really changed the nature of the work on HIV, both in terms of serving people who were already HIV positive and sending a message around prevention in the religious institutions. When I was involved in H1N1, we negotiated with religious leaders around doing vaccination clinics after church on Sundays, and that allowed us to reach people we wouldn't otherwise reach. And I think now what we're finding in terms of vaccination, for example, is that working with people in the religious community is very important in terms of if they are trusted by the people in their faith, and they have information that's scientific information to share, that can have an important influence. So I'd say yes, very important to work in that arena. With regard to rural areas, the other question, I almost think of the rural population as under the heading of equity almost, because I think that we have tended to not recognize the disproportionate burden of disease, preventable disease and injury that exists in many rural communities, in part because of socioeconomic factors, but in part because of things like distance to healthcare facilities, or even distance to shopping for food. So I think as a sector, I would say, I'm not talking about CDC, but as a sector, I think there has been inadequate attention to understanding fully what the issues are facing rural communities and the best approaches to address them. And I think now increasingly there's more and more attention to this in the Office of on Policy and Strategy at CDC, for example. There's a person who heads up rural health and pays attention to that on a regular basis, and having those specialized people certainly makes sense. So I would finally say rural communities often historically haven't been able to always compete against larger urban communities when it comes to competitive procurement, because their populations are smaller and it can seem like you're not reaching as many people. But so we need to also figure out how to ensure that we're not creating barriers to getting unintentionally barriers to getting resources into those communities, given the burden of disease and injury that exists there.
Thank you. We had a question that talked about, I think the emphasis was building upon prior experience with organizations like de Beaumont and the practical playbook, and being able to use those not as a template, but as a guide, some guideposts for moving forward. I don't know if you could talk a little bit about that.
Sure. Yeah, I mean, the materials I think that are being referenced were developed initially several years ago, and they were a response. It kind of came out of the Affordable Care Act effort and the recognition that we dramatically increased the number of people who had health insurance, but we didn't that wasn't met automatically with a stronger partnership between public health and the healthcare sector. And that mattered a lot, because as I was mentioning earlier, some of the patients public health used to provide services for moved over into got coverage under health insurance. So I think we need to make sure that we're building that kind of connection between those two sectors.
Thank you. And one of the questions I think is really interesting, being a preventive medicine training program, this idea of being able to recruit from broader sectors than just public health, seeing that decline. I try to talk with my hands on Zoom, doesn't always work, but that decline of the public health workforce and this ability to almost think outside the box in recruiting from these more non-traditional organizations. Any thoughts about that?
In terms of non-traditional organizations, is it?
Or non-traditional fields. So my most pertinent one would be like health in transit, right? There's not a great deal, like you talked about in one of your prior positions, but being able to use this funding to not just aim at what I would call the usual suspects from Casablanca, but try to have a broader aperture in who you're looking to hire.
Yeah, well, that's actually an interesting question. I think it's in some ways for me, it's somewhat easiest to think about that in terms of those entry points into public health, where I think we definitely want to do outreach to get people into public health who represent the diversity of the communities that we're serving. We want, and I think some of the efforts like AmeriCorps community health worker provide entry points for people who otherwise might not have thought of public health as a career, but might be a community leader or a community activist, maybe a community organizer. Let's try to attract some of those folks in these programs and get them into the public health sector. But I think what you raise is that there may be skills that come from other sectors that would be beneficial for a wide variety of different jobs, not just sort of at the entry level. And I think that's true of a number of jobs that, some jobs really do require public health training and expertise and clinical and scientific expertise, but some I think do benefit from the expertise that people have developed in other sectors. I would just give you the example. When in my past jobs, I have found that people who were trained by the military had incredible skills that we benefited for in a variety of jobs, such as logistical jobs and administrative jobs and technical jobs, and looking to the skills gained in that sector was beneficial. I think we have to figure out how to do better recruitment of people into the public health sector, because we're losing people to other sectors. So we're losing nurses, and we're losing, and we can't always compete, for IT folks, for example, because for a variety of reasons, sometimes salaries, sometimes job benefits of different kinds. But I think we need to think about what is it going to take for us to get the very best people interested in public health. And that, I think that we'll have to be pretty creative about the ways to do that.
Yeah, I agree. One of the questions that came in was regarding telehealth, and that's a topic that you and I both love and enjoy talking about. But I wonder if you could talk a little bit more about telehealth and its impact across a number of these topics that you had talked about before.
Yeah. Well, I certainly start out with the caveat that I'm not a telehealth expert, and so I wouldn't want to portray myself that way. But I would say, from my limited gaze, I've certainly seen that telehealth has been beneficial in a number of ways, and I'll just mention a couple of ones that I think of as a public health way. One is in terms of our interest in reaching people with behavioral health needs. There are parts of the country where there just are not easy accessible behavioral health clinicians, but we've really seen through COVID a dramatic increase in terms of the need for behavioral health counseling. By that, I mean both mental health and substance abuse related, and having the ability to connect via telehealth, really important. Distances in general, I think, can be overcome. Right now, we're worried about disease transmission, but sometimes it's just distance. We have frontier states where people just don't have the ability to travel. It's a particular issue in rural communities, as we've talked about earlier. And then I'll just mention one other area where I've seen the benefit. When I was not my current job, but when I was previously involved in working with the long-term care sector, I would see very, very fragile older adults who were in skilled nursing facilities who would sometimes develop a rash or a health condition where it was quite traumatic for them to be taken in an ambulance to an emergency room where they would sit for hours before someone would see them and say, "Oh, don't worry about that." And what I found is some of the innovative work around telehealth, where people were able to do examinations from a distance and in a number of cases avoid unnecessary transport to healthcare facilities proved to be beneficial. So there's a lot to be said for telehealth. We've certainly seen that in COVID, and I hope that a serious consideration is given to continuing it where it makes sense from both a quality and a cost perspective. What do you think about that, Tony? You're the expert, I think.
I spent a fair bit of time on telehealth this last 2 years on the response, and I agree. CDC is a part of, or works closely with HHS in this Intergovernmental Policy Council with the White House to understand where it fits in as an organization within the ideal of the federal milieu of people working on telehealth. And it certainly had grown to encompass almost half of all care amongst Medicare populations in 2020. It's diminished over time, but I think I'm interested to see where telehealth goes. I think there is certainly an impetus to keep telehealth around. I don't think it's going away, and I think there's a lot of movement towards that. There's certainly a huge push. There's about $65 billion in the most recent legislation towards telehealth or broadband expansion, and I would see telehealth as a proximate indicator or measure of addressing social determinants of health. Some people have said that broadband is a super determinant of health, and I think that's an interesting approach. At the same time, there's certain things in telehealth you can't do, and it has the potential to widen that gap in disparities. The people who didn't have great healthcare access before and didn't have enough money, although many people can afford a smartphone now in the United States, computer and internet access isn't always as universal as one would want. And I think that there will be a widening disparities at times, but it has potential to bridge that disparity over time as well. In the realm of telehealth, I think we also at the agency have included our COVID-19 self-checker and vSafe and our other automated or semi-automated applications. And those have seen unprecedented usage in the agency's history for those type of approaches. And I think that there's a lot of potential where we can, in public health, do things that help people get information that they need to make decisions and get the appropriate care they need. And then that sort of leads me on to another question about, and there's a couple of things in here about data modernization, but I'm particularly interested in, and it's my own proclivity, I must admit, about artificial intelligence and data modernization, particularly with public health, and using that example of this COVID-19 self-checker, which is a fully automated a program that's helping guide people to the appropriate care, whether that's staying at home, seek urgent care, or not. But I think artificial intelligence has could really relate to a paradigm shift in how the United States works in ways, because of this ability where you don't have to have routine tasks. They're not. There's no need for people to have to do routine tasks anymore, and that could apply all the way up to like very complex statistics or analysis of large data in the public health realm. I was interested in your thoughts about that from where you've been and where you sit now.
This is another area where I start with the caveat, not an expert, and I'm not involved in this at all at CDC. In my prior roles at in public health at the state and the local level, I found that there was I think sometimes what's referred to as artificial intelligence is really big data systems that utilize formulas to guide action steps, either patient care or public care in the public. So I guess my sort of local state public health lens was in terms of that. Absolutely lots of potential, and that the key was making sure that your formulas were accurate and the data were solid, and if you were really certain of the science and certain of your data sources, then it could be really helpful. But if there were flawed assumptions, let's just say, or uneven data systems, then just really made it hard, and sometimes you got unintentional consequences. So I'd say it's one of those areas where you really need the experts, both the public health experts and the IT experts, to ensure that it's accomplishing what you're hoping to accomplish.
And I brought it up because we as residents are considering how do we best prepare our learners for informatics in a broader way. And I think that public health has this ability to sit at a number of different tables, whether it's an analysis, almost the ethics, if you will, of informatics, how artificial intelligence is used appropriately, or large data sets are used appropriately, and as well as the complex statistical methods as well. So I find it as a fascinating component, and I also find it as a fascinating component in relation to what could be a potential divide between high-income people and low-income people. As you eliminate jobs, you've created these disparities, or these inability for people to move through these income levels in what one would ideally say is a stepwise fashion. And then once you've done that, once you've eliminated the potential opportunities for employment, then I think that is going to have a public health impact. And I'm struck by those two things, not only how it will affect public health jobs in making sure that we have the appropriate tools, and we're equipping state and local health departments to be prepared to do large data set analysis or undertake things. So I think that artificial intelligence might make that easier in some ways. But at the same time, I think you also have this social determinant of health. Maybe it exacerbates social determinants of health by eliminating the possibility of what had been during the Industrial Revolution, more a broader availability of low-skilled jobs, but artificial intelligence can potentially lower that, and you can see that in factories. That's a tangent, and I don't want to go too far down it, but I find it fascinating, and I very much appreciate all that you've done to in this federal, state, and local levels to try to look at social determinants of health, because I think those two I find to be somewhat intertwined. They're not cohesive as
well. I'm glad you're paying attention to that issue. I several years ago, this is when I was not in public health, not at CDC, Stanford was holding a conference on artificial intelligence, and I was invited to speak as a public health expert on that. And I said, you must have gotten the wrong number. I know nothing about public health and artificial intelligence. And they said, well, oh, that's okay. No one in public health does. So you can just come out and just give your initial reactions as a public health person. And I didn't feel comfortable about that. And actually, there was someone from CDC, I think, ultimately who went. But what it said to me was there was a lot of interest, and public health maybe wasn't paying as much attention to its applicability to our sector. So it's good, Tony, you're paying attention to that too.
And we did recently stand up a center for, I think it's called Data Analytics and Forecasting, that is hopefully going to address a lot of those similar concerns and be able to build our capacity internally, and then in turn help build the state and local capacity.
Yes, you're talking about forecasting, being able to do forecasting for the future, and I think that new center at CDC is going to prove to be very valuable, because we're just learning how important it is that we can have we can project ahead so that we're not responding, but we're anticipating issues, and I think that's true not just in infectious disease, but it's true in chronic illness as well as injury. So having that expertise within the agency is really an asset.
Well, I feel like I've peppered you with questions for the last, what must seem like forever for you, but I very much appreciate your time, John, for coming and all of your service to the country across public, private, and academic sectors, and very much look forward to seeing your career trajectory and all your accomplishments over time. Thank you so much, John, for coming. I appreciate it.
Thank you, Tony. It's been a pleasure.
We were going to, for our listeners out there, we're going to come back on February 2nd, the first Wednesday of the month, and we'll have another great Preventive Medicine Grand Rounds lecture, same time on the first Wednesday of the month from 1:30 till 3 o'clock. We look forward to seeing everyone there. Thank you again, John, and take care, everybody.